Welcome. In this video, we'll delve into macular corneal dystrophy, or MCD, a rare inherited disorder affecting the cornea, the clear front part of the eye. We'll explore its causes, how it develops, its symptoms, diagnosis, treatment options, and what the future holds for those living with this condition. Join us as we shed light on macular corneal dystrophy. Macular corneal dystrophy is primarily caused by genetic mutations. The most common culprit is a mutation in the CHD6 gene, which is responsible for producing a specific enzyme called corneal N-acetylglucosaminotransferase. This enzyme is crucial for the proper synthesis of keratin sulfate, a carbohydrate molecule essential for maintaining the structural integrity and transparency of the cornea. When the CHD6 gene is mutated, the enzyme doesn't function correctly, leading to a deficiency in keratin sulfate. This deficiency is the root cause of the corneal clouding and other characteristic features of MCD. The pathophysiology of macular corneal dystrophy centers around the progressive accumulation of abnormal keratin sulfate within the corneal cells, known as keratocytes, and in the extracellular matrix, the substance between the cells. This abnormal accumulation disrupts the normal organization and structure of the cornea. Specifically, glycosaminoglycans, which include keratin sulfate, are not properly metabolized or processed. This leads to the formation of opaque deposits throughout all layers of the cornea, from the epithelium, the outermost layer, to the endothelium, the innermost layer. These deposits disrupt the normally smooth and transparent corneal surface, causing clouding and visual impairment. Over time, this process worsens, leading to increasingly severe corneal opacification. Macular corneal dystrophy is considered a rare condition. Its exact prevalence is difficult to determine, but it is estimated to affect approximately 1 in 200,000 individuals. It's found worldwide, but there may be clusters of higher prevalence in certain geographical regions or ethnic groups, suggesting founder effects where a specific gene mutation became more common within a particular population. Because it's an autosomal recessive condition, both parents must carry the mutated gene for their child to inherit the disorder. This inheritance pattern contributes to its relative rarity. The signs and symptoms of macular corneal dystrophy typically begin to manifest in the first or second decade of life, although some individuals may experience earlier or later onset. The most prominent symptom is progressive blurred vision, which gradually worsens over time as the corneal clouding increases. Patients may also experience glare and halo surround lights, especially at night. Painful episodes of corneal erosion, where the outer layer of the cornea breaks down, can occur, causing significant discomfort and sensitivity to light, also known as photophobia. As the disease progresses, visual acuity diminishes, eventually leading to significant visual impairment and, in some cases, legal blindness. The severity and rate of progression can vary among individuals. Diagnosis of macular corneal dystrophy typically involves a comprehensive eye examination by an ophthalmologist. Slit lamp biomicroscopy, a specialized technique that uses a high-intensity light source to examine the cornea in detail, is crucial for identifying the characteristic diffuse corneal clouding and the presence of grayish-white opacities throughout the corneal layers. Corneal topography, which maps the surface curvature of the cornea, can reveal irregularities and distortions. Genetic testing, specifically analysis of the CHD6 gene, can confirm the diagnosis and identify the specific mutation responsible. Pachymetry, which measures corneal thickness, can help monitor disease progression. In some cases, corneal biopsy may be performed to analyze the corneal tissue under a microscope and confirm the presence of abnormal keratin sulfate deposits. Macular corneal dystrophy is often classified into two major subtypes, type I and type II, based on the presence or absence of a specific keratin sulfate epitope. Type I, which is more common, is characterized by a complete absence of keratin sulfate in the cornean serum. Type II, on the other hand, shows the presence of some keratin sulfate in the serum, though it's still deficient in the cornea. These classifications are primarily based on laboratory findings and may not always directly correlate with the severity of clinical symptoms. Recognizing these subtypes can provide some insight into the specific biochemical defect, but the overall clinical management is often similar. Currently, there is no cure for macular corneal dystrophy. Management focuses on alleviating symptoms and improving vision. Initially, conservative measures like lubricating eye drops and ointments can help manage dry eye and corneal erosions. Bandaged contact lenses can also protect the cornea and reduce pain. As the disease progresses, surgical intervention becomes necessary. Penetrating keratoplasty, or full-thickness corneal transplant, has traditionally been the most common surgical approach. However, newer techniques, such as deep anterior lamellar keratoplasty, or DALK, which involves replacing only the affected outer layers of the cornea, are gaining popularity as they preserve the patient's own endothelium, reducing the risk of rejection. In some cases, Phototherapeutic keratectomy, or PTK, a laser procedure, may be used to smooth the corneal surface and reduce irregularities, although its effects are often temporary. Post-operative care is crucial to prevent rejection and infection. Since macular corneal dystrophy is a genetic disorder, there is no known way to prevent it from occurring in an individual who has inherited the mutated genes. However, genetic counseling and carrier testing can be beneficial for families with a history of the disease. Carrier testing can identify individuals who carry one copy of the mutated gene and are therefore at risk of passing it on to their children. If both parents are carriers, there is a 25% chance with each pregnancy that their child will inherit the disorder. Genetic counseling can provide information about the risks of inheritance and available reproductive options, such as preimplantation genetic diagnosis, PGD, or prenatal testing, allowing informed decisions about family planning. The prognosis for macular corneal dystrophy varies, depending on the severity of the disease and the individual's response to treatment. Without treatment, the condition typically progresses, leading to significant visual impairment and potential blindness. Corneal transplantation can often restore vision, but it's important to note that the transplanted cornea can also eventually develop MCD, although this may take many years. Therefore, long-term follow-up is crucial to monitor the graft health. Recent research is focusing on gene therapy approaches to correct the underlying genetic defect. These therapies aim to deliver a functional copy of the CHD6 gene to the corneal cells, potentially preventing or slowing the progression of the disease. While still in early stages of development, gene therapy holds promise for a more definitive treatment in the future. Ongoing research is also exploring new diagnostic techniques and strategies to improve the long-term success of corneal transplantation.